Okay.
This is the knee pain workshop. The main objectives of today is just overview of knee pain and talk through like I said, there's two big groups. So if we can talk about those two big groups a little bit, we can spend more time on the ones that sounds like that's predominantly most people here from what you guys have been telling me so far. How it can present, and then how to manage knee pain. That'll go further into what's the benefits of like what we do here as far as rehab, PT, exercise, but also what other methods are there that are out there to manage knee pain, like injections or surgery or you name it, like creams and all that stuff too. I'd be happy to go in depth as much as we need to there as well. Very common as far as prevalence of knee pain. As people get older, knee pain tends to develop more and it's more common. In general, like 1 in 4 people report an episode of knee pain every year, and that's like across all ages. Primarily more women than men on average, and then majority are over the age of 50. As people get older in general, there's usually more just health related things that come along as far as like different joint related things, arthritis, you name it, those canes kind of develop as someone ages. But to add, it's, as we're talking younger populations too, it's a very common injury as well to your knee. Second most common injury with like adolescent athletes or younger adults as well. So everyone here has knee pain, it sounds like, but everyone probably knows someone with knee pain or has done surgeries or other stuff in the past too. So it's very common. So that's the first thing, is that you're obviously not alone, as you know. But just wanted to add that to start. The two main types, these terms might not be used often, like in like doctor's offices or things you read online, but it just kind of helps us as PTs categorize the two, and hopefully it makes sense to you guys. There's intra-articular knee pain and extra-articular knee pain. And all that means is intra-articular is you have knee pain that arises in the joint of the knee itself, like the spot that actually hinges around. Extra-articular is knee pain that comes outside of that knee. So we're talking like muscles that move the knee that are on the outside. That's where the pain origin is there. So examples of knee pain in the joint or at the joint could be like the joint surface itself could be irritable, like symptoms of arthritis. Could be other tissue in the joint itself, like a meniscus. Could be related to ligaments, if you stretch a ligament or strain it. A lot of other things fall in that category that might be given by doctors as far as the diagnosis goes. But to us, it's you've got pain in your knee, let's manage that, versus pain outside the knee. That's more of like a muscle sensitivity or muscle pain or injury, or a tendon, which is just what connects a bone to muscle. Yeah, totally. Yeah. So a lot of times there's certain movements and tests that we can do to determine which one someone's dealing with. But if they got both when we break it down, then you could very much have both going on at the same time. A lot of time, if someone has limitation due to something joint related, their muscles might not be as strong over time, and then maybe this stuff develops because of this, or one causes unable to move as well. You might be a little less conditioned when it comes to like knee strength and things. So it's areas are having to work harder than they usually are, and maybe that can develop some knee pain for the like muscle or tendon there too. So those are the two groups. We're going to break out those a little deeper next. So intra-articular, that's knee joint itself. Typical symptoms, pain at like joint line of the knee. So it could be like inner side of your knee through here or outer side here. It could feel like it's deep in your knee or like behind your kneecap. But we're talking like primarily this kind of zone is where someone's having knee pain for something that's joint related. Could be painful when putting weight into it. So that's not only like stepping up on things, but it could just be if you're standing on it for a while. It could get stiff if you don't move it for a while, or if you try to see how much you can bend it, it might not bend all the way. Those are all like common symptoms that follow. Okay, it's knee pain, but it's probably a joint related issue. A lot of times first thing in the morning, later in the evening, or like a lack of movement can just make it feel more uncomfortable and stiff. But maybe like midday, once you're up and moving, or once it's like not those like later hours, could feel more comfortable. And then main common things that people will come in and say, hey, I'm having pain with this, is if they're like stairs, walking, squatting, like getting out of a chair, standing for too long, those kind of things. So a lot of these can be common with the extra-articular knee pain, which is now more muscle tendon, but they differ a little bit. A lot of time, this pain is more related to like where your muscles actually are. So like pain right above your kneecap, like on this like soft area here, or like right below your kneecap down here. Those spots are more of tendons, which transmit force through your knee to allow it to move. That's a common site for this knee pain that's outside of the knee joint itself. These are usually common for individuals that are active. They join a gym and they start doing activity that they're not used to, and then it's kind of too much for their muscles to handle. This could be something that causes that kind of knee pain. Pain with palpation, usually, like if you press on the tendon spot, it's usually pretty sensitive and sore. And then most of these people have a warm-up phenomenon where they start exercising or moving and it hurts pretty good in those spots. But as they get moving, that tendon or muscle gets warmed up, and then they don't really feel any pain for a while until then they get on the tail end of it and that starts to bother them again. So that's a pretty common symptom for this group of people. But aggravators could be pretty similar. So like stepping movements, it's really anytime you're having your muscles make your knee move. So stepping, squatting up and down, jumping is common, running or sport-related activities are common. So is everyone getting an understanding of like the two different types that I'm trying to kind of pull out here? This might show up as far as like a diagnosis from a doctor as a tendinitis or tendinopathy, which is just a sensitive tendon, either to your patellar tendon or quad tendon. It could be muscles that run on the inside of your knee, muscles that run on the outside, here or lower. That's an example of extra-articular knee pain. So what can PT do to be helpful with those kind of things? Overall, when it comes to like cost of the like medical system as a whole, like less of individual, but more of just like across the board, much more cost effective than the other options, which are typically like injections or surgery. Like those all cost hospital systems and insurance a lot more money than it costs to do conservative care. So naturally, if everyone could do conservative care and not go to surgeries or not do injections, the medical system would be a lot less expensive. So that's like an overarching goal of what this is after. But as far as cost effectiveness too, sometimes deductibles or copays could be pretty expensive when it comes to surgeries or injections or like MRI testing and imaging. Like those can be pretty expensive just to get an MRI. And that's not necessary to be at PT, and those copays could be used for something a little more personal or like custom to you seeing a PT versus having to do all that stuff that might not be necessary. Reduces your risk for unneeded surgery. So where being in a spot like this could have like either pushed back surgeries or changed them or prevented them. That should always kind of be the first go. Like if conservative care has not been done before you're considering like a major surgery like that, it's usually recommended because more times than not, it's very effective at either prolonging, if we're talking joint replacement, prolongs a joint replacement or like entirely prevents. I had someone a few months ago, I was in the Victor office, but she completely canceled her knee surgery because she was feeling so much better. And that's just a cool moment to be a part of. There's always risk for surgery, being the knee outcome might not be as expected, or there's always risk for infection or other serious health stuff can happen with surgery. The most adaptable thing to your body is the stuff that you've got. And although there's degenerative changes for a lot of people when it comes to like arthritis and things like that like usually warrant something like a knee replacement, it's still tissue that adapts all the time. Like although it looks different on an image and it's behaving differently, it's still constantly fixing itself, changing itself, and adapting to the stresses around it. And that can't be said for like an artificial knee. Yeah, thank you for mentioning that.
So motivate me. How long?
These are just some papers to kind of back what we're talking about here, but this was just a big study that looked at if people have osteoarthritis and they have knee pain, and we get them doing an exercise program, how do those people do with function and pain compared to those that aren't doing an exercise program? And the results were strong, being that if you have someone do an exercise program that works on strength training, aerobic training, like gets your heart rate up and moving, that's tailored to them. Generally, they have less pain compared to the group that did not do something like that. And their function improved greatly too, because they got stronger, they're moving better, they're feeling better, they're more confident, they kind of know more about what's going on.
I take the
Pain and PT, so this is more of the extra-articular muscle and tendon stuff on the top. But basically, again, these especially, if you have muscle-related pain, strengthening that muscle or that tendon is very much effective in managing muscle-related knee pain too. So regardless if it's joint pain or muscle pain to your knee, exercise is very helpful compared to those that aren't doing that kind of stuff. This goes on to what I was just kind of mentioning, being like what else can be helpful here. We'll go more into your questions too about like other intervention strategies from maybe other doctors or providers. But as far as like what you could be doing, especially if we're talking osteoarthritis, it's a global, throughout your body, like a inflammatory issue to that area. So there's lots of things that have been shown to be helpful in managing osteoarthritis, and more importantly, just like managing the pain to it. Usually, if someone has arthritis in like their right knee, maybe they don't have pain in both knees, but their right knee really hurts. They get an x-ray, it shows that they have osteoarthritis. Their left knee probably has it too, whether they got an image of it or not. But if that knee likely has it and the right likely has it, why does this one hurt and this one doesn't? So we don't necessarily have to change much about like the structure of the knee, but it probably makes sense that we do some stuff to try to manage the pain to it. PT is helpful, but other stuff that can be helpful too for managing the pain, just adhering to the College of Sports Medicine activity guidelines. So these are a bunch of smart doctors that determined that if people exercise this amount of times per week, their overall health is significantly better than those that aren't. And the more you go past this number, the better and better you'll do. As far as like all-death mortality, cardiovascular health, strength overall, arthritis, you name it. If you're doing these things, you're probably better than the person that's not doing them. Those guidelines are in a week doing at least 150 minutes of moderate aerobic activity. So that's getting your heart rate up to like a moderate effort, being maybe if you're exercising, it's tough to speak a sentence or you have to take a breath after you finish a sentence. That's kind of a good way to gauge it. Or at least 75 minutes of vigorous activity, aerobic. So that's you on the bike going really fast and then you can't even speak words for a little bit. That's that kind of movement. So either way, one's a little bit less time spent than the other, but it's because one's a lot more effortful than the other. And then 2 to 3 days a week of resistance training. So that's lifting weights for your like arms, legs, that kind of work, versus aerobic activity is heart rates up. So that's like bike, swimming, elliptical, treadmill, hiking, you name it. That's the stuff that gets heart rate up. So although we're talking knee pain here, even if you did something that was just like gets your heart rate up and gets you moving, that gets your circulation going, that gets different chemicals in your knee that like drive nociception and drive pain. It gets that stuff flushed out. Like it's just a helpful thing to be doing. Even if it's not specifically like you're doing this motion with your knee repeatedly, you could be on like a arm bike just using your arms. In addition, all this other stuff, healthy fruits and veggies every day, 3 to 5 servings.
heard that one.
Drinking 64 ounces up to your body weight in water every day is recommended. Again, that's just to, if your body is hydrated, it's helping circulation, it's helping stuff move good things in, bad things out of areas. Protein is a very big one. Usually people are underdosing the amount of protein they are recommended to be eating a day, and that's set as 0.6 to 0.8 grams of protein per pound of your body weight. So if I weigh 140 pounds, I might be getting like, 100 to 120 grams of protein per day, something like that. Managing sleep well, it's recommended at least 8 hours, but that's not for everybody. But do what you need for sleep that makes you feel like well rested by the morning. A big question a lot is like, does my weight have anything to do with my knee pain? Or like, if I lose weight, will that take less stress off my knees? There's been more studies on this, and it seems that people that do manage their weight tend to do better than people that are overweight or obese. But it's not so much of like the extra weight on your knees as it is more of the having extra fat tissue or adipose tissue that tends to leave things feeling inflamed in your body, which can then drive more symptoms to knee pain versus like the weight itself. So it is effective in having weight loss, but not so much for the reasons that most people think. And then managing stress is another big one. If someone's pretty stressed out on things and not able to take care for themselves in certain things, that could also just like leave you feeling up here and can have symptoms up and high.
We're retired.
This was just a thoughtful thing that I thought was worth having. So is a lot of times people will come in and say like, hey, I have knee pain. I don't have an image. Is it helpful that I get an image before I come to PT? Or we are direct access here, which we can talk to more later, but you can just come in the door and see us with the insurance that you have most of the time, depending on the insurance. So some people are coming in without a doctor's referral and they're like, do I need an image? As you kind of brought on with your question about the meniscus tear, most of the time images show us information that was maybe already there before you started bothering knee pain. And then most of the time, what people have on images show up with other people with the same thing but don't have symptoms. So it's hard to say sometimes that thing that you see on the image is necessarily correlated to your symptoms. The example I used earlier being, you might have knee pain on this side and you get an x-ray and it shows arthritis, and you might get the same thing on the other leg and it shows the same amount of arthritis, but this one hurts and this one doesn't. So generally people like with arthritis are more likely to have pain, but it's not that you will have pain if you have arthritis. So that's kind of the two good things to that being, one, it's hard to say that your symptoms are coming from something that shows up on an image. And two, well, if this knee doesn't hurt and this one does, and they both look the same, we could probably make your knee like this one again and not have to move through with like other interventions like surgery or whatever else there. So it's kind of actually in our favor that the images might not tell us as much as we like. So kind of already mentioned, but like what will or how will PT help, or how will, like if you guys decide to see Casey or myself or another PT here, what's going to be helpful to that? Overall improvement in strength and function is huge. That allows you to do a lot more even if you have pain. So like if you couldn't do the stairs before, like it hurt too much to even do stairs, or you didn't have the strength to get off the ground, and now even if your pain was the same, but now you can get off the ground when you couldn't before, that's still a good improvement in function. It might help you live your life to achieve the things you want to do, even if you're still managing pain in some regard. The other thing too is it does seem to be very helpful usually with managing pain too. Like the more function someone has and the more active they are at doing PT, pain generally tends to follow. And a lot of our plans of care here are set around managing pain, managing your symptoms. So that's like all part of our goals. And with that, re-exposing your knee to challenging, tolerable movements that retrain your body to know that like, oh, this movement's not a threat, I can do this kind of thing. And that's sometimes when someone's got chronic pain to an area, helping your body learn like, hey, this isn't a protection thing, we can probably do this. The pain in your knee is usually like your body being like, hey, something's fishy here, I gotta make sure everything's okay. But if we can show that, that's also usually helpful in managing the pain that you have as well. Which leaves you feeling limitless. That's my Casey's got a case now to kind of pull this all together, and then we can answer questions.
So this is gonna be like an example patient with someone with knee pain, and we're gonna walk through kind of what the treatment looks like, and like this is a patient too, so like how she did. So we have a 64-year-old female with right knee pain at the medial joint line. It happened a couple weeks ago when she planted her foot and twisted, and she heard a pop. Symptoms got worse, limiting her from doing yoga and her daily activities. So on eval day, the biggest thing was education. So with examining everything, I found that it was actually intra-articular and it was a meniscus, but I just went with like the broad term intra-articular. I taught her education on pain and how to deal with it. So the biggest thing we highlighted was the traffic light. So you know how a traffic light is green, yellow, red? The green is pain, 1 to 3. It's safe. We're good to go. The pain in the yellow is 3 to 6, I say. And that's like, let's be cautious, let's watch it, but we're still in a pretty good spot. 7 and up is the red, so that's where we're gonna stop. The reason why we're stopping there, well, one of the many reasons, is because when you go that much into pain, it sends signals to your brain that go back down to where you're having pain, so the knee, and it will guard and say protect, 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 so you'll never heal. So that's why we want to work with some pain. When we work with pain, we know we're hitting the right tissue, but we don't want to go too much into that pain. So the biggest thing with her was squatting and yoga. With yoga, it was kneeling, twisting positions, changing positions. She did yoga that was more like your yoga, very gentle yoga. I actually got to go experience it with her to understand like what she was doing. So she was doing that kind of yoga. So I had her squat, no weight, couldn't do it, pain. I had her do this towel gapping technique, which I put a towel underneath her knee, had her hold it, and had her go into knee flexion, so bending her knee. What this did was it opened the joint. So then when I had her do 5 more squats, it was less painful. I also did another retest of having her do a 4-pound short arc quads. So that's now the reason why I think this decreased her pain with squatting is, like Mitch said, it created a pump. So it kind of flushed out the bad stuff, brought in the good stuff, and kind of warmed up that joint, bringing blood flow to the area. So for that day, I sent home with 2 exercises to work on. I said, I want to see you twice a week, and we'll work on this together, get through this. She was sent home with the knee gapping and the one I just showed you. So then later in the treatment plan.
So this is kind of what you might expect, like first visit if you were to come here for initial eval, where we'd take a lot of time to understand what's going on. We would do some quick testing to like confirm what we think is going on. And then following that, trial a couple exercises that we think are best fit for you based on what you told us. See how it goes, check a couple things, see some progress, and then that's what you leave with day 1. Start working on those things, and then moving on past that would be like what Casey has here.
So this was in the middle of her plan of care. So I was checking with 2 things with her at home. So her knee pain with yoga and how she was recovering from sessions. She ended up having, we found later on, with end range knee extension. So when straightening her knee, she had a lot of pain with that, and pain with step ups. Actually, at this point, she hit her deductible. So she was like, I want MRI. I want to feel at peace with everything. I said, go for it. She got the MRI. It was a meniscus. So that didn't change anything we were doing, though. I told her that it wasn't going to change anything, but she just wanted to know exactly what it was, and she found out. So then our treatment sessions from there on out was looking like a warm-up. For a warm-up, now this is just one of the many we had, but doing 6 calories on the bike. So again, getting that good pump, good blood flow. Doing bodyweight squats just to warm up a movement because you can start tolerating these now. So first we started either like at a high table. We have high tables over there, so not going as far into the knee bending. And we got lower and lower. And then the knee gapping. So the whole purpose was let's get a blood flow going, increase heart rate. Let's do something that's kind of irritating, but let's make it feel better with the knee gapping. So let's make it all work together. After that, we hit our main primary stimulus, which at the time was weighted step-ups. So I would just have her go like this, up and down with weights in her hand. She had 2 10-pound weights. This was difficult for her for balance reasons and also just strength and pain. But this cleared up pretty fast. So once we hit like the main stimulus of what was bugging her and strengthened that, I got to some accessory movements. So at this point, we were really just focusing on general strengthening of the knee. So I was hitting hip stuff. She was doing hip thrusts, so targeting the hips too. She was also working hamstring stuff, so in the back of your body instead of the front. So we worked back, sides, and front of the legs to get the whole entire knee strengthened and stabilized. And then at home, it was doing these movements that she's already seen. The biggest thing here was we started jumping things, but towards the end of her visit, she started having pain with like rushing around. So it's no longer things like every day. It's like these random little spurts, like nitpicky of where's pain. So like when she's running late to appointment, running to the car and running errands, all that stuff. She was still having pain with kneeling. We had to work with that with like placing towels when she was doing yoga exercise like that. So again, a warm up, but now we're working more on back squat, and we did weighted back squats. We worked up to her doing a 100-pound back squat. We started at 15 pounds and slowly built up strength for that. Again, you see similar movements, accessory movements, hitting all hip and knee muscles. Avoided surgery from this. And I've had a couple of patients avoid surgery from just strengthening and building up tolerance to strengthening and appropriately loading that muscle. So I thought she was a perfect one to share with you guys because she really made great progress. Yeah.
And all this stuff this whole plan is tailored to this
Yes.
person. Like they wanted to get back to yoga, they wanted to do all these things, but this is like for any of you, this final visit, this graduation visit, this is like the thing that you had trouble with doing, like that's now your last visit, right? We've checked that off. We're celebrating that. This would be an awesome opportunity then to talk about those activity guidelines for how you can continue working on exercise on your own. Usually I'd like to set people up with some sort of like gym program they can do, or get them a resource that they can go, or get more support from a trainer if they want more support, like whatever it is, make that last visit do that going forward too.
Yeah.
I'm finding out now.
Okay, so key points from today. Intra-articular is going to be at the joint, the knee joint itself. Extra-articular is going to be the outside, so the muscles and tendons. A combination of strengthening and aerobic exercise is effective in improving function and decreasing pain in your knee. Getting over 150 minutes per week of moderate aerobic exercises, greater than 75 of vigorous aerobic exercises, and 2 to 3 days of resistive training is going to help you overall, along with the nutrition guidelines that we talked about.
So this is all.
Physical therapy can reduce the risk of unneeded surgery, harmful medications, and all of that. I've seen it happen. I've witnessed it.